Welcome. Welcome, everyone, to this month's special event, co-hosted by RISE and HSPN. Everybody is checking in, joining in, signing in rapidly. I love the ticker count. And if we just move to the next slide, we'll let people know, please open your chat box and click on the to button. Make sure it says to everyone, and then let us know where you are joining us from. Welcome to Diane from, I think that's North Simcoe. Welcome to Emily from Montfort. Welcome to Stephanie, joining from London Health Sciences. Welcome to Ashnor from KW4. Florence from London Health Sciences. Madawaska Valley, Kelly, welcome. Welcome to Marnie from Orange. People from all over Ontario, Ottawa, McMaster University. And Kelly, we know you're with us too, from East Toronto Health Partners. So lovely to have people. Elgin, welcome, Diana. Betty Lou, Chair for the Ministers, Patient Family Advisory Committee. Welcome, Betty Lou. We're so happy you're here to join us today. I think it's going to be a wonderful opportunity for all of us to share and have this new opportunity in the co-hosted event with RISE and HSPN. I'm really looking forward to all of today's materials. So it's going to be absolutely wonderful and lots of fun. I'm going to learn, you're going to learn, we're all going to learn together. Welcome to Andre from North Simcoe, Sherry from Thunder Bay. I am actually today speaking from Belfast, Northern Ireland, and many of your colleagues from the Ontario Health teams are here with me at this International Foundation for Integrated Care conference, the International Conference on Integrated Care today, representing many of the activities from Ontario Health teams. And I'm sure some of them will be signing in, but many of them will be watching this after the fact because they were sorry. They were like, oh, this is a really important one for us to join. And we will step ahead and in today's event. And if we could just go to the next slide. Thank you. And so even though today I'm technically out of the country, we are acknowledging that the event is being hosted by the University of Toronto, and the University of Toronto is for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and today still home to many Indigenous peoples from across Turtle Island. And it is my great pleasure, my team's great pleasure, to have the opportunity to work on this land. And I know people on this webinar are from many different treaties and territories across the province of Ontario and further abroad even. So we welcome you to acknowledge the land that you are joining us from. We are very, very pleased and privileged to host today. And we have a fantastic event today. The next slide highlights it a little bit. But first, we're going to have a quick little poll. If you could let us know if you've joined us for an HSPN event before. We're always interested to know on whether you've joined us here or not. So click in to the poll, and we have many, many people joining us. So this is it's a new series we're launching today, so I'm very excited about this opportunity. And let us know if you've joined us before. Oftentimes it's 2/3, 1/3. And I think we still people coming in. I'll give it a few more seconds. Okay, I think that's pretty representative. It's been stable for a few minutes. We could show it up. And if we can share that out, we can see today that about 78, almost 80% of people have joined us before. So welcome back. We're so pleased to have you. And about 20% of people are newly joining us for the first time. So you are in for a treat today. It's a great opportunity to join us as we launch a new series in learning health systems. And today we are very, very fortunate to have an excellent all-star lineup. to really lead us into this material. And I think on the next slide we have, yes, the people who are joining us today. So I will pass it over very, very soon to Dr. John Lavis, who is the co-lead for RISE, professor at McMaster University, and also the lead for the McMaster Health Forum, which is an excellent source of evidence for health system reform and policy in the province of Ontario. And broadly, it's very generally applicable, actually, the McMaster Health Forum. We'll also have the great pleasure of Maureen Smith, who's a citizen partner with the McMaster Health Forum and is also on the Ontario Sport Support Unit board. Maureen Smith is a very, very active citizen representing patients, family caregivers, and citizens in many, many activities across Canada. And I believe Maureen's actually joining us from Montreal today in a conference where she is presenting and hosting. So welcome, Maureen. We also have my good colleague, Dr. Robert Reid, who's the co-lead for RISE, also a senior scientist at the Institute for Better Health and the Hazel McCallion Chair in Learning Health Systems. So you can imagine the knowledge and experience that Rob has had. He's a mentor to me in learning health systems. And we have the great fortune also of Dr. Kelly Smith, who's a chair in patient-oriented research at East Toronto Health Partners, Michael Garron Hospital, inaugural chair out there. And they have really been living and learning the learning health system from their inauguration as an Ontario Health team. And so Kelly has agreed to come and talk a little bit about their experience. I see people still coming in and joining and letting us know where you're joining us from. Appreciate that. Keep that coming all the way through so we can have that opportunity. And so I think now I'm going to turn it over to John to kick us off on this event.
Great. Thanks very much, Walter. And thanks on behalf of myself, Maureen, and Rob for having us today, along with Kelly. If we go on to the next slide, and I should just say that we call this the Pico version of the Nano course because we run a regular version of the Nano course, 90 minutes, very intense. Today, we're going to dance across some of the key highlights of that course. And then as Walter has alluded to, you'll have a chance to do some deeper dives into some of the topics that we'll be dancing over today. As we noted, we have Maureen Smith with us, a citizen leader. She has to be off to another event at 10 minutes to the hour. So we are going to make sure we get through her section by then. We have Rob Reid, who we hope is going to be joining us on his iPhone shortly. He's been having some connection problems. And then myself. And we typically offer this at least once a quarter through the Ontario Sport Support Unit, but we've also done bespoke versions for about 4 or 5 provinces and territories so far who are interested in adapting this approach to their own provincial or territorial health system. So let's move on to the next slide, which is the objectives for today. You'll see that there's 4. One is demystifying this idea of a learning health system. Second, moving beyond what I think of as kind of the American approach to learning health systems, which is all about data analytics, to note that there are many things that are needed to drive learning and improvement. We're going to come back to, in the next objective, the 3-legged stool. So it's not just what Rob calls health system operators, researchers, and citizen partners, but within the learning and improvement space, there are many forms of evidence needed, not just data analytics. And then there are a number of assets in the system, like quality improvement teams, that are also key drivers of learning and improvement. Maureen's going to handle most of objective 3. That's the part that we need to make sure that we get to by 10 minutes to the hour. And then we'll just touch very, very briefly, just with a slide or two, on moving from pilot projects, which we excel at in Ontario, to making any change for the better the new normal, which is not something that we tend to excel at in Ontario, but that too needs to become the new normal. Our format for each objective is to ask you 1 or 2 questions at the top. These will typically come up in the form of polls. We'll introduce some ways of thinking about the topic or the objective under discussion, and then we'll open it up for any rapid fire comments and questions that you're willing to share in the chat box. Just looking to see if Rob is online. I don't see him yet. So let's move on to the next slide. The next slide is 2 questions for you. So if we could pop up the poll, we're asking you 2 questions. One is if you could just pick one primary role you play in a learning health system or in the health system. If the idea of a learning health system is new to you, which role would you pick? And then we'll see if we can get an open-ended question into the poll as well in a minute, but let's just wait and see what the distribution of participants are. So I can now see that Rob is online, which is good because in a few minutes I'll turn it over to him to introduce the framework that he led the development of with many partners across Ontario, and which is now starting to get a lot of traction across the country as a whole. So we're seeing a fair number of responses, and probably now is a good time to share the poll results. So lovely to see a lot of system and organizational leaders, just under half of you. As Maureen noted, wonderful to see about 1 in 10 of you are citizen, patient, caregiver, community leaders. A little higher proportion, professional leaders, just a few people from government and some researchers as well as a couple of folks who didn't fit into one of those categories. So that's great. I didn't check in advance with our HSPN colleagues whether we can do an open-ended question. If so, could we pull up that next one? What does a learning health system mean to you? And if we can't do that, I'm going to suggest putting it in the chat box, but hold off on that until we see whether we can post the question.
I think we're going to ask that people put
Just
that
in the chat. Great.
into the chat box. Yeah, so
Yep.
please answer that into the chat box.
Wonderful. So if you don't mind, try 10 words or less. What does learning health system mean to you? So you're in the elevator, deputy minister. It's your first chance to picture on how important it is that Ontario really embraces the idea of learning health system. And she says to you, what is this stuff? What's this jargon, learning health system? Thank you, Maureen, for getting that question in the chat box. A continuously growing system, letting the academic researchers run the system. Gosh, that sends chills up my spine, Monroe. Other comments, 2 so far? Learning and developing a more effective health system. Great, gathers information from patients. Oh, they're going by fast now. I better not try and read them because they quickly disappear. So I will keep going through these slowly. Keep putting them in the chat box. I'll keep going through them while Rob introduces the framework that we're going to be talking about in more detail today. So let's go on to the next slide. And Rob, I could see you off in the distance on your cell phone. Do you want to come back on camera, and I'll turn it over to you for this next set of slides?
Yes. Can you hear me there, John?
Yep, perfect.
Oh, great. Yeah. Well, thanks to everybody. So we're having a bit of technical difficulties today, so hopefully everybody can hear me. This model, John, just jumped in here. We created it in Ontario that really tries to conceptualize what a learning health system is and all of the different components that have to go into it. And you'll see that it's set up as an engine. And it's set up as an engine because patient partners and our system partners really could understand what an engine is. That a bunch of gears have to work together with a variety of fuels and accelerants, and then has a bunch of brakes and moderators to really create some production functions. And the production functions for ours are health, experience, both patient and provider, health system efficiency, with equity right in the center. So equity isn't a separate aim, but equity is an overarching aim that has to apply to all of those other aims. And within the the action of the learning health system framework here are really some underlying gears that really reflect the types of evidence that we need to use in a combined way to create movement in those wheels. And so maybe, John, we can talk a little bit about those individual gears, as we call them, as to what those actually are, if we can go to the next slide. So these are the 5 gears, and you'll see that one gear is substantially bigger than the other gear, and I'll talk to that in just a minute. The first step in learning health systems is actually understanding the nature of problems that we're facing. We have to articulate the problems that we have that we're trying to solve in our OHT, and generally that comes from data. So generally, the first gear is all around population-based data analytics and understanding the nature of the problem. But in addition to just to regular data that we derive from our EMRs or our administrative data, we also use qualitative data here to describe the nature of the problem. So it's also about patient stories, and those actually also reflect the why the problems are occurring. So for always, we start with advanced data analytics, and we're happy to be here with Walter today because he runs some of the best data analytics in the province. The second gear then actually is an externally focused gear. It's called evidence synthesis and supports here. So it's really understanding the nature of the problems, the nature of solutions that other people across the world have come to solve some of the problems that we've found and articulated in the first gear. So this is an external gear that uses advanced synthesis methods to synthesize the information or the evidence from external places across the world, put it in context so we know what worked in other places and why, so that frames a basis for solving problems in our communities. The third gear, which is the biggest gear, is really around co-design. And this is about using advanced methods then to bring in the data perspectives, the synthesis perspectives, together with the perspectives of our diverse communities and bring together with frontline people, patients, caregivers, providers, as well as the people who finance care and so forth, to derive local solutions. Because we know that solutions have to be tailored to local context. So this is understanding context and tailoring. It's particularly important to tailor solutions to equity deserving groups because we know that one size fits all solutions generally don't work. And so they have to be appropriately tailored to different groups of people. The fourth gear then is really around the implementation gear. And this is bringing around the evidence around advanced implementation science, because it doesn't matter how well our solutions are designed. If we don't consistently implement it so it reaches every patient at every time, we fail in achieving outcomes for our solutions. And so this is about advanced implementation science. And we get into the themes of leadership, behavior change, and really methods around implementation here. So that's the implementation science gear. And then the fourth gear, the last gear, is really around evidence, feedback, and adaptation. So this is about using advanced realist evaluation techniques that will give us a quick in the moment understanding whether our solutions are working, whether they're not, how they need to be reshaped, feeding it directly back into our system. Maybe we need changes in design, maybe we need changes in implementation strategy, and it's this constant repetitive evaluation that goes forward. And so that's those are the learning gears, John.
So on to the next slide, whoever on the HSPNs. Yeah, thanks.
Oh, I went through these slides very briefly, John, but these slides for everybody, these are an articulation of each of the gears and some of the sample questions, for instance, in each of those gears. So I won't go through these individually, John. I just went through them in narrative form right there, but
Okay.
these can be left behind for everybody to read.
Great. So let's just cycle through them shortly, just so that you can see each one has a description, sample questions, both of which we'll come back to, and health system affinities. So assets that we have in the health system that play critical roles in each of these gears. And we'll again come back to this. So thanks, Rob, for that summary. So any comments or questions from any of you about what we're talking about when we talk about a learning health system? We're going to do a deeper dive into a lot of this, but if there's any questions, please put them in the chat box. And to answer your question, Irene, we will absolutely be happy to send out the slides later. And you'll see Walter's note, the video as well will be posted. And when I went through the comments, most of you had brief definitions that are very aligned with the way that we also are thinking about learning health systems. A few of you foregrounded data, and we certainly agree it's one of the absolutely essential forms of evidence that are critical in a learning health system. But in this next section, we'll talk a little bit more about some of the other forms of evidence that are also critically important.
And John, maybe I can jump in here. People may be a little bit thinking, we've seen this somewhere before, and you will see, this is, in many respects, not terribly novel. It is modeled after quality improvement cycles, right? It is about that cyclical improvement of quality. So now we are extending this to use robust sources of information to not only improve quality, but to change fundamentally design and that sort of thing. So it is mimics after quality improvement cycles, the same idea, but now we're just adding to it. So some people will refer to this as quality improvement on steroids.
Great. And quality improvement at all levels. We're going to come back to the fact that these learning and improvement cycles can happen at the level of the Ministry of Health or Ontario Health, at the level of organizations, both Ontario Health teams, as well as their partners and hospitals, primary care practices. They can happen at the level of clinicians and clinical teams, and they can happen at the level of patients, families, caregivers, and citizens more generally. And that's where Maureen's, that last point is where Maureen's going to expand. So let's move on to the next slide, which is getting us into objective 2. Moving beyond data analytics being the single driver to capitalize on recent innovations that can bring multiple forms of evidence and business intelligence to bear in ultra short timelines. So let's jump on to the next slide. We'll start to unpack this objective in a bit more detail. And we again have two polls. The first one that we're going to put up is, imagine a world similar to if you're renovating your kitchen, you don't want to have to hire the plumber, the tiler, the electrician, and so on separately. You want to bring in a general contractor. So think about in evidence world, a similar model where you can go to a general contractor who says, oh, for that question, I would bring in the data analytics folks as a key trade. For that question, I bring in the evaluators. For that question, I bring in the evidence synthesizers. So our question here is, what kind of evidence-related trades are you most familiar with? And here you can pick any of them that apply, or as many as apply. So if you're familiar with all of them, you can select all of them. If you primarily know evaluators, you can pick just option C. So I somehow got rid of the private view of the chat that I had. So maybe I'll leave it to my HSPN colleagues to say if it looks like the numbers have stabilized, a decent number of people have answered. Maybe you could share the poll. So there we go. So data analysts win out. They're always the most popular kids in town, despite my effort to bring in all the other folks. Next biggest, qualitative researchers. That's a delight to see. Not very often we see that. Absolutely essential if we want, for example, to know how racialized communities have experienced a health system problem, what their experiences have been with attempted solutions, what their sense is about how different implementation strategies may have failed them. Absolutely critical to speak to them and learn from their diverse experiences. Next up would be the evaluators, and then some of those other groups a little bit more buried back in the pack. So data analysts first, qualitative researchers, warms my heart, coming in at number 2, and evaluators number 3. Great. So let's move on to the next question. Simple yes or no. Do you know an evidence-focused general contractor who can bring together many forms of evidence in a timely, demand-driven way? If I was answering this question, I would say yes, and I would give you the example of Sarah Viebeck's office at the Public Health Agency of Canada, so the Chief Science Officer for FAC. She, in a way, acts as a general contractor for evidence questions from across the agency, and she may say, oh, we need an evidence synthesis. We can go to these 2 internal teams or these 4 external teams. We need behavioral and implementation science. We have a unit dedicated to that in-house, but we also know several good teams across Canada who we can turn to. So do you know that kind of a general contractor who can mix and match the question emerging from the system, whether it's at the level of patients, families, or caregivers, or government policymakers, and mix and match it to the right trade or the right form of evidence? So can we pull up the poll results on this one? Maureen, what do you think? Are we going to have a majority no?
Yeah. I think the general contractors are few and far between.
I think so too. In a couple of these workshops, we've had a very high proportion of yeses, which surprised me because it feels like a new breed of workers. Most people, at least in evidence world, are trained in a particular trade. They're trained to use a hammer, everything looks like a nail, and so on. So I'm not seeing the yeses. Oh, they're coming in the chat box. Sorry, they didn't come up as full.
You have to use the chat to respond to
Okay,
that one.
sorry about that. Okay. So Maureen, did you happen to see them go by? Because I'm only queuing in.
Yeah, there's lots of no's.
Lots of no's. Okay.
Mostly no's.
Not surprising. But you know who one of the groups is that I think is so well positioned to become general contractors are the Health System Impact Fellows that CIHR has been supporting nationally for many years now. In Ontario, they've been supported provincially. That group of people embedded in health systems are uniquely well positioned to move often from being a trade to become not just a trade, but also a general contractor.
Yeah, John, I completely agree with you. And in the history with many of the OHTs is this is the road that some of those impact fellows really played. And it was very helpful, is my understanding, to some of the OHTs. So particularly well positioned to really broker all of this learning health system material, John.
Great, thanks, Rob. So let's move on to the next slide, having now seen your responses to those 2 questions. So 7 features of a learning health system. Combination of a health system on the one hand and a research system, at least that's how we used to talk about it. You're going to hear about the 3-legged stool in a few minutes that puts patients, families, caregivers, citizens more generally equally front and center. But a system that is anchored on patients' needs, perspectives, and aspirations. So patients, families, caregivers, front and center, the system is there for them. Driven by timely data and evidence. Now we talk about 8 forms of evidence, supported by appropriate decision supports. So that can be, for example, embedded in electronic medical record, reminders and prompts for frontline clinicians. Aligned governance, financial, and delivery arrangements. So who gets to make what decisions? Governance arrangements, financial arrangements, how money flows through the system, delivery arrangements, how we organize ourselves. All of those things are in service to using evidence to drive change in the system alongside or to support those patients' needs, perspectives, and aspirations. And it's enabled with a culture of and competencies for rapid learning and improvement. So we try things, we realize we're not getting there with one or more patient groups or racialized communities. We work with them to try new approaches and learn again and adapt as needed. We move on to the next slide. Two actions at the heart of a learning health system. Rob noted, in a way, this is quality improvement and on steroids. It's learning and improvement cycles at all layers. So quality improvement often originated with a focus on teams and organizations, but this is applying the thinking at all levels, especially in partnership with patients, families, caregivers, organized around tests of change, drawing on many forms of evidence, and involving folks on the research side, the evidence providers, on the health system operators side, QI teams, frontline clinicians, and so on, and patient and family partnership at these many coal faces, right? From where Betty Lou operates at the provincial level to the particular organization and practice, Patient, Family, and Caregiver Advisory Council. But the second piece, make any change for the better, the new normal, and not yet another pilot project. That's where those decision supports come in, the aligned health system arrangements, and the culture and competencies to lock in whatever is found to be the better new normal. We move on to the next slide. What is a change for the better? So in Ontario, you'll sometimes hear the quintuple aim. At RISE, we tend to use the language of equity-centered quadruple aim metrics. And the reason is that equity should be at the heart of everything that we measure. Are we equitably improving health outcomes? Are we equitably improving care experiences? Are we equitably improving provider experiences? Are we equitably keeping per capita costs manageable? So we tend to mainstream the idea of equity in all of the measurements rather than separate it out as the fifth part of a quintuple aim. An example of doing this with health outcomes, in Ontario, we've tried for years to focus mostly on curve one, trying to shift that population to the right, more people who are healthy, and also narrow the curve. So there's less differences between the haves and the have-nots. And that first curve is about trying to get better at reactively providing care to those who walk through the door. What Ontario health teams are doing, which is a massive transformation and in many ways the most exciting part of the new model, they are being given the responsibility to proactively get the right care to all those who need it. So they segment the population into groups with shared needs, shared risks, shared barriers to accessing care, and then co-design solutions for each of those population segments. They will eventually get to curve three, where we start to think about groups and populations, improving housing, addressing income disparities, a variety of other things that we do at the level of a group or population. We move on to the next slide. I mentioned before the layers involved in learning and improvement. So this can happen up at the level of the province. It can happen at the level of Ontario health teams, can happen at the level of hospitals, primary care practices, at the level of clinical teams within any of those organizations, but also at the level of patients, families, and caregivers, and at the level of citizens and communities. So again, a lot of this thinking came out of that kind of meso level. We need to get better at capturing service provider voices in service data, getting them to participate in tests of change, getting them to tell the stories that can make any change for the better, the new normal. But we also need to be engaging people up the line, government policymakers, system leaders, in making every change for the better, the new normal. And we need to support the capture of family voices, patient data, engaging patients, families, and so on in tests of change and in telling the stories that can make any change for the better, the new normal. We go on to the next slide. And here I'm going to draw from Rob's earlier vision of the gears and just note that you can go from the gears to key questions, and he alluded to these, and to relevant forms of evidence. So gear one, where are the system gaps? He noted as a question, where are the inequities? Gear 3, what evidence-informed solutions exist? How will we adapt or design them with input from system users and communities? Gears 4 and 5, does the model work? How and for whom? What adaptations are needed to cement and scale? And if you just click once more, you'll see the forms of evidence coming in. So very often teams will quickly draw on stocks of existing evidence. What data do we have? What qualitative insights do we already have? Can we draw on evidence syntheses to learn from other health systems? When we come to Gear 3, what evaluations have already been done? Again, what qualitative insights are key? Then when we move on to Gears 4 and 5, this, as Rob noted, is where the behavioral and implementation research comes in. And it's also where those flows of new evidence can be created. We can generate new forms of data analytics. We can undertake new types of rapid evaluation to support that implementation, feedback, and adaptation. On to the next slide. And I need to get moving here so I can turn it over to Maureen. Our question for you here, who are the evidence trades supporting learning and improvement cycles and making any changes for the better, the new normal? And you'll see some groups that you may be familiar with in Ontario, ICES, Inspire PHC, our colleague Brianne Woods and colleagues at NOSM for data analytics. Lower down, you'll see folks like us at the forum with evidence synthesis. A bit lower down, OTAC, the Ontario Technology Advisory Committee, just some examples of some of the assets that exist in Ontario that can be drawn on here. On to the next slide. And then if you think about learning and improvement platforms that can help make change on the ground, happen on the ground for Ontarians, here are some examples of those. Ontario Health Quality, they do audit and feedback. They support quality improvement plans. They have regional quality programs. They support a community of practice. They undertake or host educational events. RISE, I see Mike Hindmarsh and colleagues on the line. They're supporting Ontario Health teams to use a population health management approach, both as coaches and by hosts of peer sharing and learning sessions. Some of you will know the Center for Effective Practice, playing a key role with academic detailers, reminders and prompts built into EMRs. We also have Choosing Wisely Ontario that tries to reduce unnecessary tests and treatments. So again, a lot of assets exist in the system to help to drive change on the ground. On to the next slide. So I'm not going to go into this in detail. I'll just say that that general contractor that we referred to before, in addition to mixing and matching forms of evidence to support learning and improvement, they can also support governments and system leaders to make better decisions by mapping forms of evidence to steps in the policy cycle. And here they would draw on domestic evidence, or ideally Ontario evidence on the left side. They draw on global evidence. They almost always say, what are other health systems doing? What's coming down the pike through horizon scanning work? Let's talk to key people through key informant interviews. So the general contractor can also pull these types of forms of evidence and other types of information in to feed up to government advisory and decision-making processes. So let's keep going. I'm not, let's leave the questions about this part if it's okay. I'm so conscious of the time. I want to make sure Maureen has time to speak to her slides about the third leg in the stool. Maureen, can I turn it over to you? Let's go right to the next slide. How do we put patients, family, caregivers, citizens more generally as the third leg of the learning health system stool?
Thanks so much, John. Hi, everyone. So I'm at the Health Data Research Network conference in Montreal, so that's why I have to leave. I'm a member of the Citizen Advisory Council, so it's very interesting. Can you go to slide 31, John?
So this is the poll. So let's.
Oh, sorry, no.
Yep.
Oh, so I've got different numbers past that. The one just before the bench.
Sure, we'll come back to the poll later. So let's keep going a few slides later.
Yep.
There we go.
Okay, so here we go. From a perspective, from a citizen perspective, is it the newest buzzword? We've heard lots of buzzwords, so sometimes patients and carers and citizens are a little skeptical when they hear new buzzwords. So what does it mean in practice? And I'll talk a little bit about the three-legged wobbly stool, which I've been talking about for a couple of years now. So how are we moving beyond it, and how do we move beyond it? And what does this learning health system actually mean for patient outcomes and care experiences? We've got all this lovely gear system in there. Who rotates those gears? And how can we, patients, clients, caregivers, communities, be part of the system? Those are the questions that when I've gone to my colleagues and people in this world who are engaged in the Ontario healthcare system, these are the kind of questions that they ask. So and of course the whole notion of learning healthcare system is one that is very easy for us to understand, and we'll go to the next slide and I'll explain why. So my heading is we're more than just data donors. So that's really important. So that learning health system where you're embedding research into the health systems and continuously learning from data and translating those findings into care and services in real time, well, it means much more than data donors, but it also means it's something that we're thinking, oh, wasn't it always that way? So we're really interested in getting the research, acted upon, and when we hear about how many years it takes from research to action, that's very discouraging for patients who are waiting for care. So there was a scoping review done of the learning health system articles from 2016 to 2020, and they found that articles discussing the level of patient involvement in learning health systems were scarce. So there's not really a really good roadmap to follow. So there's no common language or tools or frameworks for discussing and operationalizing the learning health systems that exist, and making it likely that many healthcare institutions are using the approach without explicitly naming it as such. And so you may be involved in the learning healthcare system as a patient and not even know it. So the tools that exist are often not suited to engaging people in communities with diverse voices and needs, and particularly those from equity deserving groups. So that's why the stool is wobbly, is we still have a lot of pieces to figure out to balance those legs. So next slide. So there's so many roles for us as patients and clients and families and communities in the learning healthcare system, but there are challenges and opportunities. So we have the role of being, we want it to be patient, client, partnered researchers, and the engagement that's based on the CIHR grant system is often not suited to building sustainable engagement capacity once the funding is used. So develop these relationships, and then the funding is over and you have to let those people go. And so the patients and caregivers and community leaders don't really necessarily see the impact of their efforts. There's also this wonderful group that Betty Lou leads of patient, client, and family advisory councils in Ontario, very, very strong. And next to them are people like me who do patient-partnered research. And there's this opportunity now to dismantle the silo of the people who are involved in the patient-partnered research and the people who are involved in the quality improvement work, and because they're both vital components of a successful learning health system. So we were siloed, but this is an opportunity to bring us together and learn from each other and let people move in and out of one or the other role. And we can advocate for quickly acting on analyzed findings of patient-centered patient-client data collection at the local level through those advisory councils. So they play a really important role. Then, of course, there's all of the players, the Health Accord, the Ontario Health Teams, which you all know about, and other system transformation initiatives. And I would say that those groups are making strides, but there remains a wide variety of roles for people like me and a range of capacity building initiatives. And we need greater communication of our successes and sharing of best practices, and also mentoring of patient and carers who want to engage in this work. And finally, there's all of the institutional governance bodies, and we know that patient and public involvement can be tokenistic, and that meaningful engagement requires training for all involved. And we are looking at a culture change, and that change management does require that culture change to occur. So I'm off to my last slide. Next slide. So I would, personally, I think the pathways to moving forward is to communicate clearly to patients and clients and caregivers and communities how their feedback is used in the learning health system, and how that data collected is used to improve patient-client care services with concrete examples of impact. And I'm thinking of the work that Carrie Kaliski does in that area, where she's shown them the impact and worked with them to co-design based on the data that's been collected. So it's very important that we do that. You have to determine yourselves, your health system. Do you have the workforce? Do you have the capacity? Do you have the infrastructure to nurture that continuous and impactful engagement? And then set goals to support engagement, goals that are feasible. So maybe start smaller and work your way up, and increase the level and intent of the involvement of these patients, citizens, carers in your health system improvement activities by learning from best practices. And we absolutely want to be part of the solution and be an integral part of the learning health system. Wow, right on time.
Thanks very much, Maureen. I think you have to go, but let's go back to the poll, and we'll let you sign out if you need to go now, please do, but let's go back to that poll question. So
okay, thanks everyone for accommodating
thanks,
me.
Maureen.
Enjoy the rest of the session. Oh, I'm reading what Betty Lou said. Yes. Thanks, Betty Lou. Okay, bye.
Great. So let's we'll just ask you if you could answer poll 4. What has been the focus of any patient, family, caregiver, community groups with whom you've worked? Select as many as apply. So just read through that list and let us know which of these you have experience with, either as a patient, family, caregiver, community member, or as somebody working with those groups in these particular roles. So we'll give you a second to respond. Rob, there's a question here about the role of AI in the learning and improvement cycles. I know I have an answer for gear 2. You don't necessarily need to answer it now. We can come back to it later, but just keep in mind that question.
Maybe while we're waiting for the poll, John, I can take that one on.
Sure.
And then and we'll start that. AI is increasingly becoming important in all of these gears. So, it's not a particularly focused in one area or not. It has important applications in many places. Particularly in the advanced analytics place, I think AI can really help us understand the nature of problems, who's in our system, who's not, what's their predictive ability about having problems, and so forth. And it's particularly applicable at the meso level, which is the individual clinical level, but has a lot of applications, or it's at the micro level, but has also applications at the meso level. So watch the space in AI that I think we will be seeing a lot of work in that first gear. Be careful. I just remember about equity in AI. We always have to keep equity front and center, and AI has certainly potential for creating more problems and solutions for some equity deserving groups. But AI has a whole host of other potential applications. For instance, in implementation, really smoothing our work, getting rid of barriers, reducing paperwork, making implementation easier for teams. So there's many places, John, that AI has a potential to apply in this work.
Great, very helpful, Rob. So it looks like a lot of people, about 90% of you, have experience with patients, families, caregivers providing input through, for example, advisory councils, and a slightly lower percentage of you have experience with engaging them in co-design events, and then a smaller proportion, again, in the role of providing input as a community member. And then maybe if we could just share the poll so others are seeing it too, it could just be Rob and me who are seeing it now. About half of you have experience seeing patients, family, caregivers in governance roles. fewer of you have had the opportunity to work with patients, family caregivers, or citizens when they have been the subject of the research, or as a partner in the research, or as a partner in providing evidence synthesis and support to support a learning health system. So fascinating set of responses there. If we now go on to the second question, which we'd asked you to put in the chat box, and we're going to show you a slide about this in a minute. So we talked about the three legs in the stool: patients, families, caregivers, researchers. And now if we think about those health system operators or people on the care delivery side, who would you turn to access additional capabilities that can support learning and improvement cycles and making any change for the better of the new normal? So who is sitting within hospitals, within Ontario health teams, within primary care practices, within a range of health environments that have a particular set of capabilities that are equally important in driving learning and improvement cycles? So can people put in the chat box their answer to that question? What are groupings of people on the care delivery side? Could be quality improvement teams. I could name many. You'll see a slide about this in a minute. Who would you think of that can support learning and improvement? In the chat box, I can see Walter's prompt. Does anybody come to mind on the care delivery side? If I give you quality improvement teams as one example, what other groups would be critically important? Decision support teams from Samantha, excellent. Primary care networks, yeah, we're looking here for a bit of a concrete sense about who within those networks. So providers, yes, as active participants, say in co-design events. Ethics educators, yes, as well. Other groups that are particularly likely to add value in learning and improvement cycles? Yep, Sue was saying home care providers, so absolutely writ large. So many different categories of healthcare workers who we would want to actively engage in learning and improvement cycles. While you keep thinking about it, let's go a few slides later in the deck and you'll see 3 columns. So think of these as legs in that 3-legged stool that Maureen was talking about. So the first column, those many roles that patients, family, caregivers can play in the system. The middle column is about where the researchers can come in. They may be coming in bringing their trade in which they've specialized. They may be coming in helping to play a role as a general contractor. And then we have a long list of people on the care delivery side. So somebody mentioned, I think it was informatics. You'll see that there. Audit and feedback units. So many entities in Ontario receive practice reports, for example, about their performance. User-centered design teams, change management experts, librarians may be helpful. Indigenous knowledge keepers may be absolutely critical. Rob, do you want to add anything here? This links back to your 5 slides about the years where you talked about health system affinities. And I found this part really helpful to think about who's out there that are key partners in this work within the system.
Yeah, John, I think there are many key partners and they may be in different agencies, right? They may be in the public health unit or they may be in the hospital system. But these are the people that generally I think about that really play a role. One of them that's really crucial in the implementation sphere is all the project management teams that implement projects and know how to implement things in hospitals or in health systems. Those teams are often not thought of in terms of learning health systems, but a very centrally important group.
Absolutely. And given, Rob, the answers that came in from the chat box, a lot of which were focused on groupings of healthcare providers or health professionals or health workers, we absolutely have to add that to the list. I think we've taken it as a given that you would have both patients, family caregivers, and providers front and center in the co-design work, for example. I think in this last column, we'd been thinking more of capabilities unique to learning and improvement, but we absolutely have to have those health providers front and center in all of this work, understanding problems, thinking about solutions, thinking about how we reach the people who most need care.
Yes, couldn't agree with you more, John. That has to be centered in what's doable, what's realistic, and what is within the bailiwick of different individual healthcare providers. And just put a nod in again. Always think about equity deserving groups. So whether it's from the provider group or the patients and citizen group, make sure that we have representation that stretches across our equity groups, because the perspectives in one of our groups may not hold in others.
Absolutely. Let's go on to the next slide, which I think, Rob, is for you. Do you want to speak to this slide?
Yeah, this is just a take-home slide for you, and it's really kind of meant to kind of talk about where research falls generally in improvement nowadays. And it used to be thinking that research and care delivery was completely separate enterprises, and researchers were done in universities, and it somehow diffused in passively into health systems. And we know that didn't work terribly quickly or consistently. In the last 30 years, we've been on talking about knowledge translation and exchange, which is our real good attempt to bring systems and research closer together through a brokering framework where we broker the questions, and we have cross-representation on teams. And learning health systems now is really just embedding research right in the midst of everyday care. So, using those cycles and taking the best methods now that are often, really advanced these days, and putting them right in the center of care so that we can get good, solid evidence as we change.
Great, thanks. Let's move on to the next slide, which is to see if there's any questions about this idea of the three-legged stool. So unfortunately, Maureen's not here to answer them, but happy to take any questions either about this objective or the one that came before, mixing and matching different forms of evidence. So any questions or comments that people have? We just have one objective left, which we're going to cover very shortly, and then we can open it up again for questions. We're also going to turn it over to Kelly to get her additional comments on where this learning health system is taking us. All right, let's go through these last few slides then, and then we'll let Kelly jump in, and then we can always take the slides down so we can see people if that's helpful. So the final piece, which we're not going to go into in detail, but it's this notion of moving from pilot projects to making this the new normal. And if you go on to the next slide, we have a question for all of you, which we're hoping you will answer in the chat box. Can you give an example of where you helped to turn a pilot project into the new normal in a health system? It sometimes feels like these examples are vanishingly few in number. We have so many pilot projects in the Ontario health system. Who has been involved in an initiative where a pilot project was undertaken? It was shown to really move the needle on one or more of the equity-centered quadruple A metrics. Everybody agreed this should become the new normal for all Ontarians who could benefit from it. And then the necessary changes were made in order to make it the new normal, to ensure that every Ontarian who could benefit had the opportunity to benefit from it. Can any of you give us an example of turning pilot projects into the new normal? Any examples? Rob, can you think of any? I can think of so many pilots, but it's hard to think of ones where it became the new normal. I suppose we could go back to Cancer Care Ontario, where they kind of revolutionized the cancer care delivery system. And we went from a system where you got treated very differently based on your postal code to one where, regardless of which of the 14 regional cancer systems you were in, you got very consistent, best in class, high quality care. Do you agree that that might be a good example of a system-wide effort to make optimal care the new normal?
Yeah, and Rob's just gone off now,
Oh,
John, to get to talk to the board
okay,
where he is. But we do have some examples coming in the chat
great.
around Jerry MedRisk, which I've heard of as well. I'm also flow typing in around the ambulatory surgical centers within public funded hospitals that then other hospitals have visited and received consultations and moving it along. Helen Lung talked about maybe the high priority community strategy, which is small and scaling up a little, not quite to provincial level yet, but I think definitely sustained. I was involved in the integrated funding model pilot project, which was 6 individual projects that were looking at bundled care. And that I think was subsequently adopted and scaled up province-wide in hip and knee surgery with more planned. So certainly we do see a few of these, but I think the dominance is still pilotitis.
Absolutely. Great to see. And Mike Highmarsha said, supporting providers to deliver self-management support to patients. Gosh, things move by quickly. Ontario self-management support programs across the province. Okay, Mike, interesting one. Betty Lou, I think the evolution of peer support for informal and outside the system to the current professional enabled and equitable roles in the system has been an amazing trajectory. Great. These are great examples that we can keep coming back to. Oasis Seniors Support Living started as a pilot. It's created 18 sites across Canada for its current evaluation. Wonderful. Okay, great to see some of these pilots then being locked in at a bigger scale and systematized so that more people can benefit from them. If we quickly go to the final slides, remember this is the Pico version of the Nano course. In the more in-depth version, we walk through a few examples. This comes out of our work with the RISE coaches like Mike, and as many people know, the Ontario Health teams are focused on integrated clinical pathways. So this slide is to help people see a connection between those integrated clinical pathways and then the bigger care models, which we talked about with Gear 3, but also this bigger picture transformation happening because of Ontario Health teams, the move from primarily reacting to people who walk through the door to a system of also engaging in population health management, proactively getting the right mix of services to the people who need them. And that is what we call population health management. So the care models piece needs to be integrated within that bigger whole. So implementing integrated clinical pathways, a current big focus in the system. And then if we move to the second slide here, what we have is that risk pyramid that I talked about before, healthy patients at the base, increasing risk, increasing complexity, and then highest needs patients at the top. And so the coaches are working with Ontario Health teams on learning and improvement cycles, organized around tests of change, and drawing on some of the key Ontario Health team building blocks. One of the building blocks being patient partnership and community engagement, another performance measurement, quality improvement, and continuous learning. So trying out these clinical pathways in a way that is consistent with this province-wide push to start to use population health management to proactively get the right mix of services to the people who need them. And then the building blocks are particularly helpful also at thinking about how do you make any change the new normal. And you can do that by building these new approaches into electronic electronic medical records and other digital solutions. You can do it by changing leadership, accountability, and governance arrangements, which is happening with Ontario Health Teams. And you can also do it with funding and incentive structures. And Walter, a moment ago, gave the examples of an integrated funding plan or approach that can be a way of changing or making the new normal something that has been found to make a difference. So keep in mind that we have to be thinking from the beginning about how we lock any change for the better into becoming the new normal. And the OHT, Ontario Health Team building blocks, give us the language to do it. They help us both think about how we pilot new approaches with patient, family, caregiver co-design, with performance measurement, community improvement, but they also give us the language about how we can lock in that new effective approach as the new normal. So I won't go into any more details. That was just to give you a bit of a flavor for Objective 4. So if we move on to the final slide, I believe it's just a summary of our objectives. So hopefully, if you're new to learning health systems, this has helped a bit to understand it's about these learning and improvement cycles. Many of us find it helpful to think about these 5 gears. And when you're thinking about how do you drive those gears forward, many forms of evidence are going to be important, but there are also extraordinary assets sitting within the health system, informatics, quality improvement teams, others that are absolutely essential as part of the mix. But when we come on to Objective 3, we have to have patients, families, and caregivers. We have to have community leaders front and center in this effort. And that's where that 3-legged stool comes out, which Maureen refers to often. And I was delighted to see Betty Lou comment in the chat box that she liked that metaphor. And then from the very beginning, we need to think in Ontario about how we move from pilot projects to making any change for the better, the new normal. So that's how we've been thinking about learning health systems. We welcome your thoughts about whether this is helpful to you. You'll see that Walter put an example in, or not an example, a comment in the chat box asking you to give examples of what roles you may have played in a learning health system. So now that you have a bit of a sense about how we think about it, do you now see some of the roles that you've played in the past being very connected to this idea in a learning health system? So I'll keep a watch on the chat box to see what kind of comments come there. And if people have any questions or comments, we can take them, but I also want to make sure we give Kelly a chance to weigh in. So why don't we move forward to Kelly? Kelly, are you okay coming in while I get caught up on the chat box?
Sounds great. Thanks so much, John. This is really a fascinating overview of the mechanics of a learning health system. What are all the pieces and the compartmentalization? So I think I'm here to share a little bit of experience of transitioning from our early stages of building an integrated care network in East Toronto to actually starting to live the values and mission and vision of a learning healthcare system. Our journey is quite a long one. We started in 2018, really just how do we come together as a group of partners dedicated to improving the health of a population. And I think that you saw many of the pieces of the learning health system talk about the population base, the community base. And we were doing really well at building partnerships and breaking down silos initially around our partnerships and really focused on our equity-seeking populations in our priority neighborhoods in East Toronto. And in 2020, we made the conscientious decision to move towards a learning health system model and taking those 5 pieces of the learning health system. We thought we were doing pretty good at having data and making decisions based on some information and population-based data, doing evidence synthesis, not trying to reinvent the wheel, but learning what others have done and actually bringing it to bear in a sort of rapid cycle process, co-designing with partnerships from the community members at the decision-making tables. We thought we were doing a great job. And so we really felt that evaluation and implementation were our weakest links within that coordinated effort of a learning healthcare system. And so from 2000 to 2023, or sorry, 2020 to 2023, we really focused on capacity building. And what we were hearing from our partners within our integrated care system was that we really needed to build some evaluation capacity at the front end, at the sharp end of the healthcare system. And so we put on a series of workshops, and we did a lot of coaching and co-design efforts around how do we build an integrated care system that had this hub and spoke model for evaluation. We had a centralized hub with an evaluator, a professional evaluator, PhD trained, who was that contractor, that general contractor that helped to set up evaluations. But really the diffuseness of how we collect data and use that information for improvement was left to the people at the front lines. And where we ended up is a lot of stories. We heard a lot of stories, and stories are fantastic for connecting the head to the heart, creating empathy, creating joy and meaning around your work. But what we found difficult is actually to connect that back to that value statement of the quadruple aim plus equity. And so our next vision was in 2023, we launched a portfolio that was going to be that contractor hub and spoke. That hub was now populated with some resources because our infrastructure was very, very lean. So having a single evaluation person was not enough. We needed to supply them with a project manager. So that project management part of implementation and taking things to scale was really key. We needed to provide them with those qualitative science experts because our PhD trained person was a data scientist. So we needed to complement their skill set with a qualitative scientist. We also needed to provide a little bit better access to data, which is probably our biggest barrier as we start to move forward collectively into this new accelerated OHT, really breaking down the silos and the barriers around data. We also learned a lot about culture, and I'm gonna, like, the cautionary tale for us was really around the culture. We found out after all of this wonderful capacity building and thinking we were doing a fantastic job around evaluation and capacity building, that evaluation, and anytime you brought evaluation up, it was really like a four-letter word. It was one of those things that people didn't want to hear, didn't want to talk about. And it was really around the culture, and people were used to being evaluated. And if we were evaluating, we were looking at and evaluating them as individuals and not necessarily evaluating the program or the implementation. And so people had that connection of being evaluated, thinking that that brought us to the other F word, which is failure. And so they didn't want to know if we were failing or not. And I think as an implementation scientist and a patient-partnered implementation scientist, we've learned that failure is important, and quality improvement is about failing, learning what works, what doesn't work. And so our next big challenge was learning to normalize failure and really having a safe place to fail, to learn how we're going to fail fast so that these cycles are faster. And so we have built in some of the infrastructure and the support around failure. We have a community of practice around failure. And that failure now extends into it seems like a little weird thing to have a community practice around failure, but it gives people the opportunity to talk about the things that they're really struggling with. And so one of our big lessons learned was having that open community of practice that allows us to talk about things that aren't going well. As an implementation scientist, I'm like, we're failing, that's great. We can start to de-implement that, get that out, get the things that aren't working out. But that's really not what healthcare does, right? So this series of pilots that has been brought up, That's what healthcare does. We have a pilot, it keeps going, it might be in the background, it's not really working, but we're going to keep our resources to it. Where in a learning health system, you identify what's not working and either see if you can adapt it to fit to that local context, or you throw it out. You've learned, you learn it doesn't work, we have another fix, bring in another co-design session. And so that's really the beauty and the brilliance of a really robust learning healthcare system. And so our big goal for 2024 is actually to break down the silos of data. So we have data sitting in pockets at each organization within our Ontario healthcare team, and we don't talk to each other. We don't share data. I'm sitting in the hospital and we have terrible data on equity. Our community health partners in CHCs have fantastic data on equity and social risk factors. And what we're going to be doing is having a community of practice around data. And we are taking the research lens, because research, you can get away with sharing data a little bit easier for whatever reasons than trying to actually do it to share from a population perspective. So that's a little bit about our journey, where we've gone, where we're coming from, and where we see us going in the future.
Yeah, thanks so much for that, Kelly. Some really excellent examples, and I think opportunities there around some of the supports that you've also had to put in place to support those learning activities. I think that's really interesting. I might ask you one other question related to this. Out here where I am, we had a panel yesterday on learning health systems, and this question came up, and it comes a little bit to the way we put together that framework with the gears. And there was some intentionality, not just to have circles, but actually to have gears that need to connect. And I don't know if you've had any experience, but how do we think about, that when we're looking at the data, then that needs to really engage with the evidence and then engage in the co-design, like along those lines, all of these kind of pieces together. Yeah.
I think it's actually purposive, and the linking is critically important. The other thing I should have mentioned is that we did make the purposive decision to have a community first learning health system. So really driving the community. So we have a community partner who leads and co-leads our portfolio. So they're at the governance table, they're at the decision-making table. And over the past 4 months, we now have a cadre of 40 citizen scientists who are able to work with us and embed in different projects. And that's all funded through my research portfolio funds the $25 an hour stipend that we give to all of our citizen scientists when they embark in co-design and co-production activities. So we do have a little bit of the research feeding into the improvement at the local level, and then that also feeds back. But I do think that you need to have that engagement. And part of the reason for bringing in community at that point was we needed to be able to translate data that comes in different forms. And I think, Walter, you've done a couple of HSPN sessions on how do you translate data from sort of us as scientists into sort of even frontline practice into improvement. And we were taking it one step further with how do you explain that and make that understandable for communities, so that communities can understand the information that we're really using to help drive change.
Yes.
And so that's like a critical piece. That's the full path of data translation. And you need patients as partners throughout it.
Yeah, thanks for raising that translation element as well, right? It's we can't use the same language for everybody. The researchers have a certain way of speaking, and citizens another, and frankly, providers and policymakers, leaders, other ways. And thinking of what that language is. There's a question in the chat, Amber Alpach, Bishop, wondering if you'll share your contact information with folks about this, but particularly she has an interest in learning more about sharing data across the OHT. Amber's from the Middlesex, London, Ontario health team. You might have one comment on that, and then maybe if you're willing to share the contact information. I know you're findable, but.
Sure, I'm absolutely fine to share my contact information, but what we're doing is a covert operation because we have hit barrier after barrier. We've been trying to solve this data governance issue since 2022, and we were just trying to get like, what are we all collecting? And we hit a roadblock in people willing to share what information that they're collecting locally. So this is about those relationships. So the other part of the interconnectedness is that relationships and building relationships within and across those different connect points along the learning healthcare system. So we do have a coalition of the willing who have all committed to sharing data. And the one thing that we are giving up, I'm going to say, as the hospital, is we're not going to be the data broker, because we are the least trusted person entity of those silos. So we are giving that to our community, our visiting or nurses association and home care has probably the most robust data lake that we have within our partners, and they're going to be our data broker for this research. So it's really giving up power. That's the other thing, power and trust. So always be really mindful of the power you hold and the power you need to give up in these relationships if you want to build trust.
Wow, what sage advice. Thanks so much, Kelly, for sharing your experiences with us today, and that leadership element, and sharing and building trust, and sharing power to do that. John, do you have any comments you want to end off on before we just go into our closing little bit?
Just that I'm hoping that my colleague James can just pop the evaluation. I think we just have something like 3 questions in it, but we'd love just to get your feedback on the Pico version of the Nano course. So if folks could take a minute to complete that, that would be great. There it is in the chat box. Thanks, Walter.
Yeah, thank you very much. And I really encourage everybody to click into that. And if we bring the slides back up, you'll see why. Today was really our introduction to the overview of the learning health system. On to the next slide. And we have, as people, 80% of you know, every fourth Tuesday of the month, we have a webinar for the Ontario health teams and others as interested, who are interested in advancing population health and learning health systems and integrated care. And you've seen this framework that we've talked through today as an overall framework. And we are going to dedicate the next at least five monthly webinars to delve in and really understand and think about the examples of how have we seen these brought to life in Ontario health teams and elsewhere. So first off on that population health analytics and insights, both from qualitative and quantitative approaches. Then evidence syntheses, what are some practices? What can OHTs trying to involve evidence in their planning? What are some ideas, keen ideas for that? A piece definitely, you see the largest gear here is on patient, caregiver, and provider co-design. So maybe there are some really interesting practices. Finally, thinking, well, not finally, almost semi-finally thinking about implementation. How do we actually go about doing this? And then coming back to something that is tried and trusted and true in this series very often is the focus on evidence and the evaluation approach to bringing in evidence about what works, in what contexts, and for whom, and sharing about how different teams are doing that. We are super keen to hear from OHTs. Please email us at oht.evaluation@utoronto.ca. Hopefully that's on the next slide or the one after. Skip this one, go to the past the team. And there we go, yes. So any of these links, hspn@utoronto.ca would be the easiest one. And go back and let us know if you have any experience related to the implementation of learning health systems and any elements of it, not the whole thing maybe as a whole, but certain aspects of this learning health system. We're really interested in engaging and having experience. We know that East Toronto had been engaged in this journey for a little while. It was very generous of Kelly to join us, and people have heard from East Toronto, but I know that people out there all over Ontario are doing elements of this, be it co-design, be it evaluation, be it implementation, or data and insights. We're really interested. Please let us know so that we can help to bring those stories to life through this event and the series of events upcoming. And I really appreciate it. Betty Lou has a comment there to close us off, and I'll give people a moment. to have a chance to look at that. And we are so happy, Betty Lou, that you are with us today. And it is so essential that we are engaged entirely in activating citizens, communities across Ontario in our local environments, in our hyperlocal environments, to ensure that the changes, modifications, improvements, advances in the health system are being done in ways that address the needs of the people we serve. Thank you. And on that, I'll let everybody off your afternoon. We'll see you next month. So pleased today. Thank you very much, John. Thank you very much, all the RISE team, for joining us today in this event. Take care, everybody. Enjoy your afternoon.